Hello, everyone. Good morning, or good afternoon, or good evening. I hope you can hear me all right. Welcome from UICC to this virtual dialogue, which is the first in our Cancer Beyond COVID-19 series. You might notice we are in a slightly different environment to what you may have been used to in previous virtual dialogues, but I'll spend a few minutes just to get you acquainted. But thank you for joining us for this, as I said, the first virtual dialogue in our Cancer Beyond COVID-19 series. And first of all, let me thank our partners who made this series possible: MSD, Novartis, Pfizer, and Canadian Partnership Against Cancer. So thank you all for joining us. I'll just spend a few minutes. My name is Alessandro Di Capua from UICC, just to get you a little bit acquainted with this new platform that we're using. There will be plenty of time for to engage and to speak with us. So I'll just like to quickly flag up. You might want to enable your microphone, which is just the top of your head. You can see the microphone sign. If you just click on the little arrow, you'll be able to enable it. But please mute yourself, obviously, throughout, unless you are speaking. There will be plenty of opportunity for you to speak in main room and in breakout room. You might also notice now there is a map. I'd like to invite all of you. You can scroll on the map and use the pin sign to put your location around the world. So, for example, you can quickly see where people are connecting from. Just as you will notice a couple of area, which is the Q&A and the chat room. I can see some people are already pinning their location, so I'm glad it works. So in the chat room, please, we really like to engage with all of you throughout the day. So use the chat box while the panelists are talking to add your reflection of comments, and the Q&A specifically to file any questions you like to ask the panelists. There will be time for clarifications, questions, and also time to engage with the panel discussion in the Q&A section. You might also notice there's a little man with a raised hand just on the side of your microphone. We'll also use that in the Q&A section if you would like to ask a question directly. So please feel free to use it as we move on to the Q&A. You can use that too. And finally, for the first one, you might notice on the little box underneath the chat, for the first time we have Spanish and French subtitles for those who might need language support. You can enable them simply by clicking on that link, and you should have access to translated captions. Please note that this will only happen in the plenary discussions. In the breakout groups, there won't be the subtitles won't be activated, but if necessary, a member of the UICC team may help with language support. I know it's a new platform, so should you have any technical difficulties, just feel free to add a note on the Q&A and let us know. But I think that's enough for me, and I'd like to move on. So today's event will last approximately 2 hours, and I'd like to turn the microphone over to our chair for the day, who's Sonali Johnson. A note on the Q&A and let us know. But I think that's enough for me.
I can hear a little bit of echo.
And I'd like
Can everyone hear me properly? Okay, there's a little echo, but hopefully it should be all right. Good morning and good afternoon, everyone. It's really wonderful to be here and to see you all. I can see a number of locations around the globe, so it's exciting to see us all internationally despite these exceptional circumstances. So here we all are, and today's webinar is a part of a series, Cancer Beyond COVID-19 series. What a very relevant topic especially as now in Europe and in other places we're going into another lockdown with implications for public health and particularly for cancer. So I'm just going to introduce myself. My name is Shonali Johnson, and I am the head of the Knowledge, Advocacy and Policy team here at the UICC. I'll start by introducing the series. So Alessandro, as you know, has introduced a little bit about the platform, but the series itself, which is really exciting and really run by Alessandro and my colleagues in the capacity building team, with input from all across UICC, and my colleagues are also on the call. So over the last month, we witnessed really extraordinary changes brought by the COVID-19 pandemic. It's something that really affects us all. Wherever we live, internationally, whoever we are all united by our experience here. And health systems, economies, and governments around the world are, of course, impacted by its implications. And while the crisis has highlighted the structural weaknesses of many health systems, and it has magnified existing inequalities in health outcomes, it has accelerated key trends that may shape healthcare and public health in the years to come. So through this three-part series of virtual dialogues, we are inviting the cancer community to reflect on some of the changes set in motion by COVID-19. And we want to discuss the implications for cancer prevention and control. We are particularly interested in hearing from you as to what actions may help transform this crisis into an opportunity to shape stronger, more equitable, and resilient health systems for better cancer control. So the series begins today with a focus on the disruption to cancer screening and diagnosis, and it will continue on the 17th of November, looking at the transformation in cancer care delivery models, and then it will culminate on the 1st of December, discussing the impact on health financing. So all very, very relevant topics. Once again, I'd like to thank our supporters for this dialogue, the Canadian Partnership Against Cancer, MSD, Novartis, and Pfizer. Today's topic. So I've already talked a little bit about it, but just to then really summarize, to give some background to this particular dialogue today. So with the outbreak of the pandemic and the related lockdowns, screening and diagnosis of cancer is experiencing major disruption. And new barriers are emerging that are limiting access to these vital cancer services. Many countries are facing a backlog of undetected cancer cases, and the consequences of this can be severe, particularly in patients presenting with later stage disease and that are going to miss, or that may miss, important therapeutic windows. As we know, we've been working hard to rectify this over the last years. Late-stage presentation of cancer is associated with poorer outcomes, worse quality of life, more toxic and complex treatment, and higher costs to patients and to health systems. But it's important to say that efforts have been made to resume screening and diagnostic services, including population-based programs. But barriers do remain, and the delays and backlogs are growing. Patient hesitancy and a reduction in referrals for possible cancers has been reported in different settings. So with a new wave, a second wave, and upcoming restrictions, there is an urgency for the cancer community to get together and to identify potential best practice accelerators for cancer screening and diagnosis at the local, national, regional, and global level. So sharing experiences, strategies, and building collaborations is now more important than ever to prevent a wave of undetected and late-presenting cancers. So that's what we're here today to discuss. And we are very fortunate to have a great panel who will talk to us today, giving their perspectives and insights into this issue. So I will introduce the panelists, and then each one in turn will talk through their introductory remarks with some slides. So I would like to introduce Eric Nicholson, who's the Director of Screening from the Canadian Partnership Against Cancer. Then we also have Jodie Moffat, Head of Early Diagnosis at Cancer Research UK. We have C.S. Pramesh, who is the Director of Tata Memorial Hospital and is also a UICC board member. And Amy Israel, who is the Vice President and Global Head of Oncology Policy and Healthcare Systems of Novartis. So welcome to you all. Thank you so much for being here. And let's start. So let's begin with Erica. Over to you.
Great. Thank you so much, Sonali. It's a real pleasure to be here today to talk about the work that we're doing in Canada with the Canadian cancer screening community and my colleagues at the Canadian Partnership Against Cancer for how we're using the pandemic to accelerate innovation with respect to COVID-19. Now I'm learning the platform and I'm trying to advance my slides. There we go. It's always great being the first panelist. Yeah. So I want to acknowledge today I'm joining from the east coast of Canada. I'm in Halifax, Nova Scotia, which is situated in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. For context, the pandemic, we are in our second wave in Canada. The pandemic really started to materialize in Canada in mid-March, and that's when we saw many of the public health policies, the quarantines, the closures taking effect. And the graph that you see here, of course, is the aggregate graph of the data from last week for our country. And hidden, of course, behind that aggregate data is the fact that not all parts of Canada are being impacted equally by the pandemic. And furthermore, as is the case in other countries, we're seeing that certain groups are being disproportionately impacted by COVID-19. So the impact on population-based screening programs has essentially been this. In early March, we saw many provinces and territories who deliver the organized screening programs for breast, cervical, and colorectal cancer in Canada put their programs on pause. And this was to create capacity within the healthcare system to manage the anticipated influx of patients with COVID-19, as well as to reroute resources towards community-based testing for the virus. I'm really pleased to share, though, that our partners, most of them have restored their population-based screening programs as of August, but we're certainly hearing that participation rates are a fraction of what they once were. And at the partnership, we have modeled the impact of what this temporary closure of screening services will mean. And as you've indicated, Sonali, we expect to see more individuals coming forward with later stage disease. So this speaks to the importance of the screening programs and the diagnostic systems really working hand in hand as we look to recover from the virus, the pandemic. So perhaps I'm an optimist, but the pandemic has provided us with an opportunity to sit back and go, what has worked well? What is the silver lining? And so certainly in the Canadian context, we've seen the healthcare system really rally and respond at a rapid pace in a way that perhaps many of us have not seen before. And so the ability to affect change, to introduce innovation at an unprecedented pace. And an example has been the introduction of digital health or virtual care technologies in Canada. It seems like this was made possible almost overnight. So for our cancer screening system, the question becomes, how do we then capitalize and capture these innovations and bring them into the cancer screening pathways? And then the other question becomes, when the system is in a state of flux and the puzzle pieces are up in the air, when we go to restore services, would we want to put the pieces back together in the same way? And I would argue that the answer is no. First, because of the system has changed and the innovations. But the second part, and Sonali, you spoke to this as well, is that there are inequities in cancer screening services and that the pandemic has really shone a bright light on the systemic inequities. And so as we restore our services and build resilient screening programs, health equity absolutely has to be at the heart of our work. So what are we doing about this in Canada? And this slide here, the resilient daisies growing out of the sidewalk, shows some collaborative work that we're doing with screening partners across the country, patients and family advisors, to really provide a guidance document that will be released later this month to help the screening system navigate successive waves of the pandemic. So there are strategies, evidence-informed strategies, all the way through from how can we be more strategic with targeting our population, how can we import risk-based approaches to triaging patients with abnormal screens to follow-up care, how can we bring in and import the gains that have been made in virtual care. And for example, how does patient and family communication need to shift with the pandemic? Bringing the policies to be able to bring a loved one with you for your screening appointment, or how do we need to communicate results and wait times in a different way? And all of these recommendations certainly are underpinned by the guiding principles that are very practical, the COVID rates within a community, thinking about supplies of PPE, but also equally importantly, equity considerations right at the forefront in terms of being mindful not to exacerbate inequalities. And in Canada, this is also an opportunity to work with Indigenous communities, to work with First Nations, Inuit, and Métis to support those communities in advancing their self-determined priorities. So the Canadian Partnership Against Cancer, we are stewards of Canada's Strategy for Cancer Control, which was refreshed in 2019 after extensive engagement. And those priorities, there are 8 priorities in the strategy that were articulated by people in Canada in 2019, I would say have taken on increased significance. And one of the core tenets of the strategy is that no one is left behind. So we really are seizing this opportunity. We're making, we call it lemonades out of the COVID lemons, to accelerate those innovations in cancer screening that will build resilience, but also hopefully reduce some of the inequities. And here's a couple of ways that we're doing that. One, we're working with partners to move towards more home-based screening. Canada has signed on to the World Health Organization's call for the elimination of cervical cancer. And in Canada, a dominant strategy to achieve that goal by 2030 is to move to HPV primary screening. And so we are learning from fellow UICC members who've made this transition and are actively working to bring HPV primary screening, which also opens up the opportunity for home-based or self-sampling for people in Canada. I also mentioned we are anticipating, of course, this burden not only from the pausing of screening programs, but it will take time to restore that strong participation rate in organized programs. And so the importance of the screening and the diagnostic and care systems working in synergy. So we're working to see how can we optimize our existing programs. An example of some targeted efforts there is to optimize the abnormal call rates in mammography and breast cancer screening. We've seen a trend in Canada where our abnormal call rates are higher than our national target. So that's an example of some of the very practical ways that we're working to support the cancer screening system. My last slide here is about inequities, and I think this is certainly something that the cancer screening community in Canada has cared about, reaching the underscreened, but it has taken on increased significance. And so how do we, as screening programs, improve our data, have more real-time data, unpack aggregate numbers to understand who is being served, who is being left behind. And as we're moving in this very dynamic and increasing innovations, to be mindful of new inequities that might be emerging. So it's not only data. I think the pandemic, COVID, has taught us that to remain resilient, we must be consciously and continuously working with communities to co-create solutions so that no one's left behind. So there are many, many opportunities, and I think COVID provides us with the impetus to create some real, lasting, positive change. So thank you.
Thank you very much, Erica. You mentioned so many very interesting points on subjects that I hope that we will be discussing further in this webinar, in this interactive dialogue. You've mentioned innovation. You mentioned digital health. How can we utilize digital health effectively to improve participation rate? How can we use digital health for patient consultations more effectively, etc.? You mentioned restoring sort of confidence and increasing participation rates in the system itself. That's how do we optimize existing programs? So these are really, really great points to kick us off, and I'm sure we will return to those as we go along. So thank you very much, Erica. So moving now on to Jody. Go ahead. You have the floor.
Thank you very much. And does very much follow nicely from Erica's presentation there. Very many similar themes will come up as I took you through a little bit about what's been happening in the UK over the last 8 months. And by way of context, I'm speaking to you from just south of London on a very windy and rainy day here. So I guess just to take us back a little bit before COVID, cancer services in the UK were in a relatively good position internationally, but still with a long way to go in terms of delivering a proper world-class service. And we were having challenges with dealing with the demand, seeing patients in a timely manner, and certainly weren't delivering our ambitions around stage of disease at diagnosis and cancer survival. So there was already a lot of work to be done. And clearly with the impact on COVID, that work is feeling like it's kind of doubled, really. We have a lot more that needs to happen. And we were very fortunate at CRUK early on to have on-the-ground networks that were reported back to us what was happening quite quickly. And we have since had quite a lot of this backed up through data, and you can see some excerpts of that on the slide. But similar to the situation that Erica outlined in Canada, cancer screening was paused very quickly. That was an official pause in some of the nations in the UK, and a kind of de facto pause in others, which was interesting in itself just to see that variation. We do have those screening services getting back up and running, but it has highlighted some challenges, some things that perhaps hadn't been thought of before. But for example, quite a lot of our breast screening capacity is delivered by mobile units, many of which didn't have sinks for hand washing facilities. So there's been a huge and quick turnaround program to try and rectify that. And also we are seeing very variable across the different screening programs and geographies, but not as many patients coming forward or participants to those screening programs as we might have hoped. And that's something that we're going to really need to see some more current data on at a sufficiently granular level so that we can understand that. We also have within the UK the urgent cancer referral route, which varies by cancer type, but a quarter to a third of cancer diagnoses come through those routes. And we saw in March, April, a huge decline in those cancer referral routes, as you can see from that bottom left diagram there. And they have started to recover, but we are envisaging that we're actually going to need to exceed what we were seeing pre-pandemic in order to get over the backlog of patients that we think are in the system. And what, of course, this graph doesn't pull out is the variation by different referral routes. So the referrals for suspected lung cancer and that, interestingly, the referral routes for suspected urological cancer have been much slower to recover than some of the other cancer types. Lung, perhaps not surprising given the overlap with COVID, respiratory symptoms related, but very interesting. We also have a significant proportion of patients who come through routine referrals, and we know that they have been slow to recover as well. So we're concerned about patients who aren't making it through into hospital settings for tests and follow-up investigations. When it comes to diagnostics, huge challenges there. We already had a significant workforce deficit in many different parts of the cancer workforce. And you can see from that bottom right graph, in particular, we have a significant issue now with patients waiting 6 or more weeks for their diagnostic test. This graph is for endoscopy, which has arguably been more challenged than any of the other screening modality and diagnostic modalities that we have. But a huge concern there, and something that needs to be addressed in order to ensure that we can diagnose these patients in a timely way. So when we're thinking about what are the main challenges now, thinking about having come out of a first wave and very much heading straight into a second wave, this is an example of a question that we asked to a small sample of GPs back in July, particularly taking up that feed about lung and respiratory symptoms perhaps being slower to recover, so going from that angle. But it really just tries to tap into some of the barriers to diagnosis and management of patients, and as you can see, kind of calls out a range of different factors. But top of our mind at the moment is two: patient confidence and behaviour, and how fewer patients are actually attending for presentation with their primary care physician, who are those patients who aren't going forward for those tests that their GP is recommending for them. And of course, there's probably a range of different reasons feeding into that. So it might be that patients are concerned about getting COVID. They might be concerned about overwhelming and adding an extra burden to the NHS, which is something we hear a lot and have done always as well. It might be that there's this idea that cancer, the window of opportunity in cancer is bigger than the window of opportunity for other diseases such as heart attack. And all of these things kind of adding together, along with the shifting formats and the move towards digitalization, which is serving some people very well, but may also be disserving some others less well. In response to that, we have seen a bit of a mixed picture in the UK in terms of public campaigns, which have sought to increase people's confidence in the NHS, reassure them that it's open for business, and encourage them to see their GP. But it is a very mixed bag. And while we have seen quite a lot of activity in England, we are yet to see too much by way of activity in the other nations of the UK. And we are mindful that there are particular groups, GPs are particularly concerned that older patients, for example, aren't coming forward, and we need to make sure that they are, that the campaigns are resonating with them and we're having the desired effect, particularly as we go into further COVID activity. The other key challenge that I see at the moment is the diagnostic capacity. And we had at CR UK been calling for a long time for increases in the cancer workforce. And if we had seen that investment and resource previously, perhaps we would be in a bit more of a resilient position than we are currently, where we have all of those patients waiting so much longer for their tests. We're having GPs who are waiting for test results. We really need that capacity to be put in place. We've seen some innovation and some reinforcing of innovation around networks and areas kind of sharing the demand across boundaries, working more flexibly, which is hugely encouraging. We've also seen moves towards thinking about triage tests and how they can be making sure that the available capacity is going to those most in need. But there is a really interesting balance there to be struck between that kind of risk assessment and triage and not missing unduly too many cancer cases and particularly early stage disease. So there's a lot there and a lot to explore. And underpinning all of this will be really key to see more COVID testing being possible within the UK, which I think will be really helpful for giving patients confidence and also ensuring that we have capacity in the system to deal with the demand that we have through COVID and through cancer. And then on the silver linings theme, so we had, so silver linings wise, I mean, the things that I put on the screen here very much relate to COVID in terms of how rapidly we've seen guidelines be developed, how adaptable the whole service and system has been, how we've seen research get off the ground really encouragingly, really quickly, etc. And this really just shows that it can be done. And if it can be done, then we can do it for cancer. And we really do need to harness this appetite, this energy, this enthusiasm, keep our mind on the long-term ambitions around reducing late-stage diagnosis, giving patients an improved outcome, and getting those systems and services back up and running, and crucially, giving patients and participants the confidence in those services so that they will take them up. That is all from me today. Thank you.
Thank you so much. Thank you very much, Jodie. It was really interesting. And, you know, the data from the UK has been really, really useful, and not just in understanding the impact of COVID on cancer referrals in the UK, but also the potential situation in other countries. And there have been some really important studies that have come out and published in Lancet Oncology and a couple of other journals recently. And I have looked at those not long ago, referring to the 2-week referral pathway, which has, of course, not been followed. There are huge delays there. What I also thought was very interesting is that you've highlighted these key factors. We could almost look at them as levers. So you've highlighted public behavior as one. You've highlighted the diagnostic access and public confidence. So we could almost look at those as, you know, thinking about what to do, you know, is even identifying certain levers that we could start to pull or to really see some change in, rather than tackling this whole huge beast in cancer. How do we start to pull apart things that we can see actions in, both in the short term and the long term? And that's certainly what we hope to start to pick apart today, but going through this series. So thanks, Jodie, that was great. Over to you, Pramesh. Talk to us about what's happening in India.
Thank you. Thank you, Sonali. And I did recollect Erica mentioning that it was the toughest thing to be the first speaker. But after hearing two stalwarts in their fields speaking about early detection and screening, I feel like some kind of an imposter trying to impose my views on something that I'm clearly not an expert on. So I'm a thoracic surgeon, so you could be as far removed from screening and early detection as I could be. But nevertheless, I'll try and draw some parallels with what we've had in India, bring in some perspectives about the experiences that we've had, both with cancer treatment as well as screening and early detection, and hopefully we'll be able to align these views together. So as I mentioned, what I hope to share over the next few minutes is about both cancer care and screening during the pandemic, and give you a perspective about what we've encountered so far in India. So as of yesterday, the world had seen close to 44 million confirmed cases of COVID and over 1.1 million confirmed deaths because of COVID. And similar numbers in India were close to 8 million confirmed cases and over 120,000 deaths. So clearly, these are pretty sobering statistics. And while we may look at the overall impact on cancer, we also need to keep this in perspective when we discuss some of the points that we are currently discussing. So as in several parts of the world, the initial response that we had for COVID in India was one of widespread panic. Panic to the extent that non-COVID diseases tended to be ignored. And strangely enough, the response was pretty discordant with the trajectory of the pandemic. So while we had a few hundred patients testing positive for COVID at the beginning of the pandemic, we had this national lockdown where people were terrified of stepping out of home, were extremely careful about universal masking and maintaining distance and hand hygiene. And when we are close to 100,000 new COVID cases getting diagnosed every day, we've somehow allowed pandemic fatigue to set in and relaxed on many of those precautions that we used to take. So I find this quite discordant and quite disturbing, actually. So when it came to treatment, there was, at the beginning of the pandemic, quite a bit of confusion about the priorities of treatment. Do we prioritize treatment of COVID-19, or do we look at non-COVID diseases as well and ensure that overall the mortality remains not so high over the expected mortality? And to compound all of this, we had the challenges of handling panic amongst healthcare workers, and strangely enough, the logistic challenges of the lockdown, which could go into pretty practical aspects which we would not have thought of earlier. As a result of all of this, cancer care and screening struggled. Hospital volumes, when it came to diagnosis, staging, plummeted quite significantly. Screening virtually came to a standstill, as I'll show in one of my subsequent slides. In fact, some of the cancer centers were converted to COVID-19 treatment facilities, which in a country like India, where you already have limited facilities for cancer care, was pretty much a challenge. And other cancer centers actually deliberately slowed down cancer care, either because of the logistics of the lockdown or a very practical issue of supply chain disruption, or increasingly a perceived risk of cancer treatment during a pandemic. So what I'll give over the next few minutes is the perspective not just from my own center at the Tata Memorial, but also the experiences of a large network of cancer centers. And for those of you who are not familiar with the National Cancer Grid, we are a network of 220 plus cancer centers, research institutions, and patient groups spread across India. As you can see, practically every state in India being represented, which between them treat over 700,000 new patients with cancer annually, which is about 60% of all of India's cancer burden. And the principles on which the Cancer Grid was founded was one of uniform standards of care, developing trained human resource, and collaborative multicentric research, all of which stood us in good stead while handling the COVID pandemic. So on one hand, we had to balance the need to continue cancer treatment and screening for our patients, which all of us in this audience realized the importance of. But at the same time, we needed to look at how could we manage COVID-19 amongst our patients, both cancer and non-cancer patients, and to also ensure their safety and the safety of our employees, which was paramount to be able to maintain routine medical services. So very early in the pandemic, we took a conscious decision that cancer care was not elective, nor was cancer screening. And while we emphasized the importance of both of these, one was easier to sell. The importance of cancer care during a pandemic was far easier to sell than that of cancer screening. And I'll show that with some numbers very soon. The reason we took this decision was the realization that exactly what Sonali and Jody mentioned about the experiences and the modeling done from the UK, which showed that several thousands of lives would be lost if we prioritize COVID-19 to the exclusion of everything else, and if cancer care were to suffer as a consequence of that. So as part of the National Cancer Grid guidelines, we came out with some principles of treatment and screening. As I mentioned, we took the stance that cancer care was not elective and needed to go on even during the pandemic. And while we realized the higher risks of both screening and treatment, we emphasized the fact that we needed shared decision-making as a crucial component of whether to go ahead with what was routine work or step back. We also needed to prioritize screening and care where the impact was more, lending itself to a choosing wisely strategy, and doing all this while ensuring universal precautions both for patients as well as for staff. And to a large extent, we depended on a stepladder pattern of prioritizing what was important and ensuring that the key elements of cancer screening and treatment were not lost amongst the confusion that COVID-19 had created. We were also sure to ensure that much of what we thought was disseminated, and we did this in a series of publications, both nationally and internationally, just to disseminate this work amongst the rest of the medical community so that they could understand and learn from our own experiences. And to be honest, we made a lot more mistakes than the right measures. But nevertheless, we felt it was important to share these experiences with the larger community. And we also did this through a series of webinars. So we started this work on disseminating this information very early in the pandemic. We ran through a series of 16 webinars which shared several aspects of handling cancer and COVID, and also just the management of COVID alone. And we went through a myriad of topics, including what our therapeutics could be, what vaccines could bring in, what testing strategy we should use, how could we triage cancer care during the pandemic, psychosocial issues associated with the pandemic as well as the lockdown. And we also ensured that we brought in all stakeholders into the picture, including nurses, paramedics, so that the important aspects of infection prevention and control could be emphasized amongst the group. When it comes to cancer diagnosis and screening, we did this recent study as part of the National Cancer Grid, where we surveyed all our member centers about how much their volumes had decreased during the months of March, April, and May, which was when the pandemic hit India, and compared it with similar figures in the previous year, March, April, and May of 2019. And we got responses from 38 cancer centers, which between them treated 1/3 of all of India's cancer burden. And what we found was that there was a 30 to 50% reduction in new cancer registrations. It's not that cancer has disappeared, it's just that these patients never reached a cancer center. So we don't have the universal set of all cancer diagnoses made in India, so I can't say this with certainty, but at least what I can be sure about is the fact that a substantial part of India's cancer patients failed to reach a cancer center. Diagnostic tests and biopsies reduced by 35%. But the more sobering figure is what you see on the right of the screen, where we looked at a fairly large screening center where their volumes plummeted drastically in the month of March when we actually started the national lockdown. And from somewhere around 800 screenings a month, it just dropped to zero for a subsequent period of 3 months. And since July and August, there has been a very slow increase in the number of screening that's being done for cancer. From another center, we saw a 1/6 level of screening compared to what we had earlier, which meant that the vast majority of individuals who were getting screened for cancer just did not get the level of screening that they required. And all screening services, including primary prevention like tobacco cessation clinics, completely stopped between March and June 2020. Outreach programs, which were discontinued in March, have still not taken off. And diagnostic procedures for confirmation of screen positives by colposcopy and biopsy have not still taken off anywhere close to what we were before. Fortunately, we've got a bunch of people who have come out with some guidelines for cancer screening and the way forward. And the summary of their recommendations is primarily that we need to resume screening. COVID's not going away in a hurry. We need to optimize screening needs, something similar to what the WHO has recommended as well, that if somebody has had a mammography or a cervical screening a year or two back, we could afford to defer the next screening a little bit longer. And everyone who comes for screening for cancer gets screened for COVID symptoms prior. And if there is a necessity to screen them for actually test them for COVID, they will get the COVID testing done prior to the screening. This is not mandatory, but based on a symptom-based triage of individuals. We needed to realize that physical distancing was required not just in hospitals, but in screening clinics as well, and follow the same kind of best practices that we did in hospitals, like universal masking, minimize the number of staff exposed, as well as the family members who came with the index individual as far as screening was concerned, regular disinfection of the screening clinic as well as the procedure room. And we tried to limit the number of physical contacts by making appointments and counseling done, getting transformed to a virtual format. Like Erica and Jody, I see the cup half full. I try to look at the silver linings. And I think there's plenty to learn from COVID. And we even have what is considered the world's greatest democracy going into an election today, hoping to change what the political aspects of healthcare are. And I'm hopeful that the results of this election will be an improvement on what we've had so far. But as far as it comes to COVID and the silver linings associated with it, never before have we had as much attention to infection prevention and control, and I see this as a positive. Whether it be a treatment facility or a screening facility, emphasizing infection prevention and control is of paramount importance. We've also learned that we need to prioritize treatments and screening more optimally, lending itself to a choosing wisely strategy. Several of the learnings we've had from treatment, like tele and video consults, have translated into benefits in screening. But to me, the single most important thing has been the incredible collaboration and cooperation we've had, which has been truly interdisciplinary and multinational. So our current guidance as far as screening and early detection is concerned is that regardless of the COVID pandemic, we need to continue this. We've realized that the consequences of stopping screening, stopping early detection and diagnosis, stopping treatment are likely to be far more severe than the consequences of COVID itself. And what we need to do is to optimize these screening needs, resist the pandemic fatigue, which is setting in large parts of the world, and just stick to the basics and go on with life as usual. Wear a mask, watch your distance, and wash your hands. And I think emphasizing the importance of screening and care can never be as important as it is today. Thank you very much for your attention.
Thank you so much, Pramesh, for that comprehensive overview of the situation in India and the work of the National Cancer Grid. And I would just like to say that your presence on this panel is also extremely important as a surgeon because, as we know, to really impact the cancer burden, it's not just screening and early detection. It's screening and early detection with early and effective treatment and care for cancer. It's not it's in outside that whole cancer continuum paradigm. And what you've talked about is so important because, of course, it's you've mentioned the conversion of cancer treatment centers into COVID centers as well. So that's affecting the whole system of cancer control right down the line. You also talk about the interruption of smoking cessation and other primary prevention. So what we're really seeing is a real disruption to the cancer control system in itself. Of course, today we're talking about screening and early detection, but of course, they're all linked. And the whole purpose of getting people early is to be able to get them treated and cared for early on, as early as possible, as we know that for many cancers, at least, this has an impact. So thank you for talking about that. That's a very important point. Now we'll go to our last panelist today, Amy Israel. You have the floor. Thank you.
Thank you, Sonali. So for those who may have joined late, I'm Amy Israel, and I'm the VP and Global Head of Oncology, Policy, and Healthcare Systems at Novartis. I've got more years of experience than I'd like to admit in designing programs to meet the needs of those most at risk and advocating for policy change with NGOs, predominantly in low and middle income countries, before joining the pharmaceutical industry, where I still keep access as my North Star. I've been impressed with my fellow panelists. Erica and Sonali speaking about equity being at the heart is something core that I'm going to also touch on. Jody, keeping our minds on the long-term needs is so crucial because cancer doesn't stop because of COVID, as you rightfully noted. And Pramesh was quite humble, as you all, I'm sure, were aware. I was impressed with the presentation he did early in the pandemic. I just looked, I took a few photos of his slides, and it was April 6th. And you did a presentation with City Cancer Challenge on a webinar when it was early days for many countries, but talking about setting up those guidelines and that grid and the network and how important it was. It was swift and needed and extremely helpful. So thank you for that. You're my cancer and COVID guru on that level. So, I also finally want to thank UICC for convening us on such an important topic. It is clear that we will be living with COVID for some time. Many countries are seeing significant upsurge in cases, and just this past week, we saw alarming data from REACT-2 study in the UK suggesting that antibodies developed in response to the virus may not be long-lived. So I approach this topic in the context of looking at adjustments that will not be short-term and can help us approach cancer screening and early detection in an ongoing COVID world. I see three issues that we can work on to prepare for not only getting back to where we were, but also to improve screening and early detection of cancers. The first is use the advanced technology that we have been developing through precision medicine to understand the different risk profiles and adjust for them. Put in place less invasive approaches that can be done at home and preserve distancing as much as possible. This would also take pressure off clinic staff. We know that cancer patients are at risk for poor outcomes if they get COVID. A recent publication by Bakuni et al. In Cancer Cell goes into much detail, but quote unquote cancer patients are not a heterogeneous group, and not all cancer patients face the same risks. There's a big role for precision medicine here to help stratify patients into risk categories. If we can understand the risk profile of patients, we can adjust screening programs to take those risks into account and to be able to assure people that it's still safe to come for screening and to catch cancers as early as possible. From the studies that have already been done this year, we know that people with lung and hematologic cancer seem to be at higher risk than other cancer patients. To name a few studies, those done by, and I'm sorry if I'm not pronouncing the surnames correctly, Racino, Pasamonte, Giancolis, and their colleagues. We also know that tumor status is an important factor as well. We have to learn more, but that's already a start to understanding what programs can be more safely resumed and which ones need extra precaution. Yeah, on the diagnostic side, the advances that we're seeing in precision medicine can be critically important in this environment. Thanks to precision medicine, we already have home testing for colon cancer with the fecal immunochemical test. Other non-invasive techniques such as liquid biopsies could replace the need for a person to show up in a hospital to have a tumor biopsy, so you'd have a safer, socially distanced procedure. These are the at-hand technologies that we can start accelerating now to build screening more sustainably for a COVID world. The second piece is to ensure that the adaptations we make are accessible and understand what kind of adjustments we have to make to these adaptations, such as digital screening, to be inclusive of disadvantaged communities and not make the divide even greater. Last month, Dora Shaw and colleagues published a study of cancer patients receiving treatment during the pandemic, and this was in the US, and they found that compared with Caucasian or white patients, African American, Black, and Latino or Latina patients were far less likely to receive a telehealth visit. So to be an effective digital solution to screening would have to be designed to address the barriers we see there. And this is an evolving area of research, but one that is super important to continue, just so we don't further the divide in reaching all populations. And the last and final point is, as much as I don't like to say COVID is an opportunity, as it's devastating millions of people, and many of us know people whose lives it's devastating, there is an opportunity, and we must seize the moment offered by new public awareness of prevention, understanding, people are now understanding more the purpose of screening to promote participation in cancer screening through opportunistic piggybacking on other programs. Prior to COVID, even countries that had very efficient screening programs, and we've heard many of you, all of our colleagues, talk about this, in place for the most commonly screened cancers like cervical, breast, or colorectal, we're not seeing full participation across any demographic. The pandemic has shone the spotlight on public health. People are more aware than ever of the importance of these measures, and they've been educated extensively on the merits and importance of screening programs. Things that were barriers to cancer screening programs in the past, convenience, fear, affordability, time, too complicated, pain, are common to the COVID screening experience, but people were willing to be screened for COVID regardless. We can harness these learnings to drive participation in cancer screening. And the last piece, which is just a nugget that I'll note, is a crucial learning from COVID testing is that the need to make sure that communication around results is timely, responsive, and easily understood. Thank you.
Amy, thank you very much for your thoughts and points on that. And then, I find it very interesting, you talk about technology, but not just making technology available, but the equitable access to technology. I think that's a really key point. And certainly that links to what we heard earlier, and Erica had raised this on innovation. And I would like us to think about that as we go through this virtual dialogue, and certainly in the rooms, the breakout rooms later, thinking about the innovation that we can really use to improve screening and early diagnosis. We should certainly not be taking ourselves from a point of where everything is working swimmingly before COVID. If we go and look at coverage rates of an uptake of cancer screening programs around the world, they are in many countries not optimal, and countries are doing their best to improve those anyway. So this is an opportunity to revisit the way we deliver our services, certainly at that end of prevention, early detection, and early diagnosis programs, how we do that better, and how we use innovation to do it. And on this side, to really kind of think through in this dialogue 2 areas. What do we do now in terms of innovation? As you say, Amy, the at-hand innovations that we can use. And then the second one is, what innovations do we use in the long term, whether that's precision medicine, whether that's something like a universal cancer screening assay, which is being developed, or looking at new digital technologies, etc. So, to keep our eye on sort of the short term and the long term possibilities in this area, so that we don't go back to necessarily the way things were before. We don't want to do that in some cases. What we want is a new paradigm that works well, but not throwing everything out. So I think it would be good for us to identify what's working well, what we could use. Some of you have already done that, and I think we can explore that further as we go through this afternoon. Now, before we go to questions and answers, I would just like to hand over to Alessandro, because he has a poll. We're running slightly behind time, so I suggest we do the poll now, and then we go to some questions and answers on a panel discussion. I hope that works for everyone. Over to you, Alessandro.
Thank you, Shonali. I hope you can all hear me. So we thought, after this interesting, insightful inputs from our panelists, maybe we can start bringing in a little bit the audience. Some of our panelists have shared the sorts of the challenges and the various barriers that they've been facing in the UK, for example. Jodie shows some of the research they made with the general practitioners there. So if I can ask the technicians maybe to pull out the poll that we prepared. So we'd like to take a little bit of a snapshot from the audience about what do you feel are the barriers in your own settings that you're currently facing in terms for the safe resumption of cancer screening and diagnosis services. So I think can everybody see the poll? I assume so. So you'll find a few options that you can so please try to pick the main barriers, so maybe 1, 2, if possibly maximum of 3, just to give us an idea where the sorts of currently the sense is. And you will be able to see the results as you answer coming through live. This might also help, Shonali, as you start the sort of the Q&A and see if those barriers also reflect those that were shared by our panelists. Just giving a few more time to allow for as many people as possible to vote. Okay, I think we have the results. And about
right.
I'll leave it to you, Shonali, to maybe to start the panel discussion, having a look at them, reflecting on this.
Staring at their screen, looking at them, they were moving around a lot, but they're very interesting and very much confirming what we've heard, of course, on the restrictions on the availability of routine services. So, a large number there, also tied with the reluctance, so this hesitancy, a fear to visit physicians and health services, and then, of course, in the population, right, that's also linked to hesitancy in coming forward when there's suspicious signs and symptoms, which, of course, is something that we've been trying to tackle through health promotion, right, and then the reluctance in the population to access services which may not be considered. So a lot of this is very much on the population level of again, the confidence in the systems that other health issues can be dealt with and should be dealt with. Fears around infection, of course. So yes, very much what the panel says. Is there anyone in the panel who would like to just comment briefly on any of these findings? Ramesh, I'm looking at you because a lot of your measures are actually tackling some of these, so that's great to see on infection control in particular, getting public confidence. Is there anything that you'd like to say about this?
So my experience will be limited to India and some of the surrounding countries like Bangladesh, Sri Lanka, Pakistan, Afghanistan. But what we are seeing here is more or less return to normal as far as cancer treatment is concerned. But what probably deters a large number of people who would have otherwise come for screening is the fact that screening is an elective option that you exercise, and they don't feel the value in getting themselves screened during a pandemic and potentially exposing them to a higher chance of developing COVID. Over the last, if you had asked me this question a couple of months back, I would have said it's the lack of screening facilities available in most centers in India and other countries. But as we speak, we are pretty much back to normal. Most restrictions have been lifted, and it's more a hesitation on the part of individuals to come for screening than anything else.
Thank you. That's certainly borne up also by the, I think, from our experience of the other participants on this call, isn't it, where you can really see that hesitancy amongst the public in coming forward. Erica, is there anything you would like to say particularly on that, and looking at the equity dimension? Do you feel that in Canada there would be certain communities who would be even particularly more impacted or reticent to access health services, who are already particularly vulnerable or marginalized? You mentioned First Nation people, Indigenous people, etc. Is there anything there that you'd like to comment on in terms of moving forward?
Yeah, sure. I think, well, first of all, I'd like to acknowledge that last week the Chief Public Health Officer of Canada issued a report around COVID-19 that really is completely focused on health equity. And I think what we will see, and this is, my armchair speculation, but as we go through successive waves of COVID-19, I don't know whether we'll see the blanket policies and closures that we saw in the beginning. What we're understanding is that those blanket policies also disproportionately impact people who may have been classically underserved or underscreened by the healthcare sector. So, for instance, hourly wage earners, right? People who've not been able to pivot and join virtual forums such as this to continue on their work. So I think when it comes to rural and remote, which is a significant part of the geography and landscape of Canada, access to mobile screening, mammography units, for example, the vans coming in. What we've heard from patients and family advisors is the need to really communicate the benefits of screening, be very clear about how your health will be protected during that screening encounter. So, Pravesh, your comments about, personal protective equipment, the sanitation procedures, etc. And be really transparent about how results will be communicated. People understand that the system is in flux. So what are the anticipated wait time for me to understand, when I will receive the result of my abnormal screen? And if I need further care, what can I expect? The other thing that has been a significant issue in Canada is patient presence policies. So I think as we move forward and want to encourage people to come to screening, acknowledging the level of anxiety that people have, not only around cancer screening, but cancer screening in a pandemic, and really working with patients to understand how, whether it's a virtual presence of a loved one during that screening encounter, if it can't be in person. So I think, it's a bit of a multifactorial response, Sonali, but I think, engaging with the communities to co-create the solutions is going to be very, very critical for us to restore confidence in cancer screening and, quite frankly, build those innovations and the resilience that we need to see in the system.
Thank you, Erica. Just continuing on that, if I may, because I'm very interested, and I'm sure others are, on the using telehealth, but also to communicate results and to communicate bad news. How has that been going in your experience? I mean, do you have anything to share on how that has been rolled out in Canada? Just to look at that in terms of the consultation process around the screening and early detection.
Yeah, I think that it varies across the country. I can't speak to specifics about bad news. I know that one of the things that mail systems have been classically a way that screening results have been communicated, and the Postal Service has been impacted to differing degrees across the country. So many jurisdictions have moved to technology and building on, I think, Amy, you talked about that infrastructure for COVID screening to get your COVID results, and how can we leverage some of the infrastructure that's been built around COVID testing to facilitate whether it's digital flow of data around screening results or other opportunities there.
Thank you.
And then, of course, I think where digital health and virtual care is really being looked to is for well follow-up, primarily around screening visits and screening results.
Right. That's a very interesting point. Absolutely, Amy. Do you have any reaction to that? I mean, really using that, the piggybacking a bit. We're talking a little bit about piggybacking on existing infrastructure, and here we have an opportunity. I keep using the word opportunity. I know you don't like it. Sorry, a possibility to be utilizing this sort of track and trace system, whatever you want to call. Not in all countries is cancer a notifiable disease. In some countries it is. But how do we use it? How do we use it effectively? Because we are seeing a lot, even when you go to restaurants now, you have to use if you have a mobile phone, you enter where you are, you can be contacted, this information system. How could we use that to benefit?
So I don't even think we need to go that digital. We have the mechanism from tuberculosis from ages ago on accompaniment. This is such a simple mechanism of supporting our community members through a process of the diagnosis, the symptoms, the treatment initiation, all the way through the care pathway. This accompaniment mechanism has ensured that millions of people complete successful treatment regimens for tuberculosis, which is curable. It has also helped identify multiple other diseases. It is then used in HIV. It's used now in diabetes and some cardiovascular, some more chronic conditions outside of HIV. And as we saw for COVID, this model, which was heavily used by Partners in Health in drug-resistant tuberculosis, was picked up in the U.S. for contact tracing as well as the accompaniment. So whether it be low tech as community members supporting each other, which has been done for centuries, to higher tech, though with the caveat to make sure, while almost everyone and their grandmother has a mobile phone, making sure that it's friendly and it's operable for the most at-risk populations. I think those mechanisms exist, and we could do so virtually and so as well. So all of the things that are tested in terms of community support and engagement have also been tested virtually and adapted. We could easily pick those up, and many settings, I'm sure, already are informally. Whether or not it's measured and the impact of it, I haven't yet seen for cancer in the context of COVID.
Thank you. That is really, really very interesting and important ideas. Wonderful. So I think what we'll do now is we'll start to go through some of the questions. We have some questions coming through on the chat. One has come through from Cheryl Cruz from the UK Breast Density Matters, and Cheryl talks about patient safety. So she's asking, inaccurate or delayed diagnosis is one of the most common causes of patient harm and affects millions of patients in countries where screening inequalities exist. So what are the panel's views of education, medically sourced or otherwise, for health care professionals and patients to promote informed conversations, shared decision-making, and more positive outcomes? I'm going to direct that question to Jody because you talked about human resources. And I wondered if in the context of the UK, is it really just about bodies, more bodies in the system, or what sort of skills transfer or continuous medical education programs do you see coming through? And is there anything that you think that the UK is planning, or other countries that could provide some insight into what sort of training could already be given if that's even possible in this particular moment in time. Over to you, Jodie.
Okay, thank you. So I guess there's a couple of things there. One's around workforce capacity, and we can't get away from the investment that's needed to actually bring more workforce. But then there's the other part of the question of once you've got that workforce in place, are they equipped with the information, the skills, the pathways, the kits, in order to be able to have the conversations with participants that ought to be had and to manage them in the appropriate way. And I think we're quite clear at Cancer Research UK that education of health professionals and supporting them in the management of patients with symptoms, but also having informed conversations with people who are considering screening is really important. The challenge, of course, comes with reaching 40,000 GPs in the UK context and how you can do that. Cancer Research UK on its own isn't in a position to do that, and even working with partners, it's a really difficult task. So how do we help ensure that there's a common ground, a foundation that's built at a policy level? And that's where our interest in the training that GPs have, that medical professionals, health professionals have, and how we can ensure that there's a basic but fundamental level of knowledge that they can then draw on and build on throughout their career and that can get added to. So I think that's really important. Cheryl also asked a question about the other forms of screening, so not just mammography screening. And I think just generally there, as we've heard, there is a huge opportunity and a need to get to more sophisticated, tailored screening based on individuals' level of risk. At the moment, we have a bit of a gap in the UK about what it is we know about our patients. We are often lacking ethnicity data. There will be other data that we don't have in order to be able to then understand what pathway and screening option is most suitable for them. So there's a huge bit of work there that needs to be done around understanding that, but huge opportunity if we get it right, and a big chance to have a positive conversation with the community and participants to help them understand the different risk stratification approaches going forward.
Thank you, Jodie, for your answer to those two questions. Thank you. We also have a question from Ana Margarita Ortiz. Does anyone have any experience they wish to share with digital virtual health platforms in low-income countries that have a lack of resources to enable this? So is there anybody who would like to speak a comment? I'm thinking, Amy, in your international experience, in Pramesh, in any of the countries in South Asia, for example, in LMIC context. Pramesh, let's start with you, and then we'll go over to Amy.
Thank you, Sonali, and that's a great question, Anna. What we've realized is, so we went through this entire exercise of enabling health access platforms from our hospital, and though we did it primarily for care, I think this probably applies even more to screening and early detection. So a few months back when we were about a couple of months into the pandemic, we realized that we needed to offer alternative solutions to our patients who were on follow-up, patients who wanted to access care for the first time, sometimes even to patients who are on active treatment, just so that we could reduce the overcrowding in hospitals. And we went out first looking at ready-made off-the-shelf platforms which offered such a solution. We, in fact, interviewed and went through demonstrations of 4 or 5 of those ready-made solutions. We went out to our patients, asking them what they wanted, and finally ended up with offering all the regular solutions that we currently have, including some professional ones. But by far, the most preferred option was some very unconventional access platforms like WhatsApp and effectively even Zoom meets and Teams were second priority. It was chat forums like, so we've got a host of them in India, WeChat, WhatsApp, Telegram, Kaizala, practically by everyone who's involved in it. And what we realized is that the convenience that a telephonic conversation offers them, combined with being able to see their doctor or healthcare provider, was by far the most important thing that patients wanted. And so we completely narrowed down our choices to what we can now consider as available options, and it's down to either Zoom, Teams, or WhatsApp. So,
great. Thank you. Amy, anything to add to that?
Yeah, a few pieces. One is a lesson from COVID, which is that the importance of patients driving the decision making. So in COVID, there have been a new number of spontaneous groups started up, especially for long haul COVID. People experiencing COVID for more than 30 days or the 2 weeks that they say it lasts. These platforms like WhatsApp, Facebook, or Slack, which I had to educate myself on what Slack is because I'm not so young and hip, but are all free to the user, and then someone might have to support the technology, especially if it's a large group, but it's not the user, and they don't take a lot of bandwidth. These have been amazing resources. They also exist and were created quite organically in many settings when the pandemic first started for networks with patient association groups, patients themselves who already were diagnosed with cancer, questions, reaching out, aligning, sharing resources, etc. In terms of the managing care or managing the results, there's a whole data privacy question that needs exploring in country by country. But sharing results or health information over WhatsApp is not always ideal or secured, and so finding the right way within your country context where you can still have safe transfer of data and patient information is quite critical. But nothing needs to be off the shelf. Now, the other piece that would be helpful is what systems that do talk to each other in any electronic medical record or any sort of digital database that they're talking to each other, especially for the multiple diseases that we now know have so much impact.
Thank you, Amy, and also thank you for highlighting. Yes, we will all need to be, certainly for the patient protection of data, etc. That important topic. We won't have a lot of time to get into that today, but of course, that is a very important aspect. We just have one more question. I would like to have at least one of our panelists answer before we go to the breakout groups, because I'm being reminded of the time. So Lucia Corden has asked, what has COVID shown us about the importance of considering and incorporating patient preferences and decisions around approval and uptake of new technology? So that's maybe a question for Jody and Erica. Can I just ask either of you or both of you just to quickly comment on that? So how do you then consider patient perspectives around the new technology aspect? Do you do consultations? What is your process? Erica.
Sure, and thanks. Great question, Lucia. I think in terms of COVID in Canada, right, as I mentioned, has disproportionately impacted communities. And so the key lesson that has come forward there is that communities absolutely have to be part of the solution in terms of framing screening and testing for COVID in a way that resonates with the communities and is supported by community leaders. And so I think that there's a direct correlation between that lesson there. And when we look at cancer screening, introducing a new screening technology or suddenly a screening kit arrives for you to do at home, we need to understand what supports that individual requires, the education needs, the communication, and even the acceptability of that test. So for me, it drives home the need to co-create solutions with community.
Thank you very much, Erica. I'm actually going to go now to the breakout groups. I'll hand back to Alessandro, and we can take some questions at the end. I see that a few more questions are coming. So unfortunately, we don't have time right now, but we may have some time at the end. Let's go to the next segment. Thank you very much to our panel.
Thank you, Shanalia, and thanks to our panelists, and we'll have a chance to hear their final thoughts at the end. But it's probably time now to get into the most interactive side. We would like to hear from you. We'd like you to talk to each other, because I think there's a lot to learn also from the expertise around the audience. So we like to send you in breakout rooms. So you'll be grouped with 5 or 6 of your colleagues, participants, and what we'd like to ask you is to probably bring your own experience about some of the new practices that have emerged in your settings. We've heard some from the panelists, but it'd be interesting to hear what has emerged in your own settings, but also what are the broader trends and changes that you think we might have emerged from this crisis that may support early detection of cancers going forward. Some have been mentioned, but it would be good to hear from you. So the way this will work, you'll be shortly be sent in a breakout group. You will find you should have your audio already enabled, so you just have to unmute yourself and be able to speak, and your camera should also be enabled. So you just have to click on it to enable your camera so your participants, your peers can see yourself. You'll also find in the breakout room a whiteboard. Please use this to sort of note key insights, some of the solutions, some of the things you'd like to share once we get back into the main room to report back, because we'll be able to pull out the whiteboard from your room, and then we'll ask each group to sort of report on it, and you can pretty much use it as you would use a flip chart while you're having a table group discussion. There will be a UICC member of staff in each group in case there is any question or any technical problems, but to save us time, so I'd like to probably send you all now in the breakout group, and I hope you enjoy the discussion. You'll have about 15 minutes, just around that, and then we'll be back in the main room, and we look forward to hearing from you. Hi, everybody. There seems to be some little problem with the audience, some of the breakout groups. So before we recall all together in here, maybe the best idea would be to just share those conversations in the main room to avoid those problems. Sonali, shall I just hand it over to you? And maybe we'll try to open the floor a little bit to try to get the input we we're trying to get through the breakout groups. I suppose we're not too huge of a size of a group. We might get some inputs in the main room altogether. Okay. Well, were there any discussions in the breakout groups that anybody would like to share? Were there any topics or questions or I would say things that will take us towards a desirable future for a screening and early diagnosis? I think that's what we're really looking for, ideas, concerns and thoughts. Is there anything anybody would like to share? UICC staff, please also speak.
Hi, Sonali. This is Julia.
Hi, Julia.
I would encourage actually from my breakout room. It was Heather and Clara and Christiana joined us in the end. Clara unfortunately had to leave, but they made a very important point, which was about the trends and changes that they've seen, which I thought was very interesting that they both, or the three of them said that the collaboration between different sectors has been a trend and a change that they've witnessed, and that's been very useful to their work. So unfortunately, our whiteboard got a bit messy, but it is under trend. So I wanted to highlight that point and thank you to my breakout group for that important contribution.
Thank you very much. Self-sampling, direct screening tests, more collaboration. And just from that group, are we talking about collaboration with other health areas? Could somebody from the team just elaborate when we talk about collaboration? What would be the model? What's the proposed model? Maybe it's Heather or...
So Heather, who introduced the points, I hope she'll be able to sorry, that was my timer, to add to that comment, Heather, if you have the option. I see you unmuted yourself, so I'm going to mute myself.
So this is Heather. I think we talked about it in several ways. I think we've seen in...
It's faint. Can you talk? You're a little bit far from the microphone, sorry.
Okay. So I think we've seen it in several ways. In a jurisdiction like ours, we have actually put together a document to support the jurisdictions in moving forward with screening. But I think that we also had a contribution from Clara that said she has found that coming from an advocacy organization, that the collaboration between the advocacy organizations and the providers has also been enhanced during this. And I don't know that there's a structure for that. That sounded to me to be more organic.
Thank you for that. Thank you very much, Heather, for that. Is Clara there? I'm sorry, I don't. Did Clara have to leave? Is that correct, Julia?
Exactly. Unfortunately, Clara had to leave. So yeah. So Heather, thank you for adding to that.
Thank you. Is there any other any input from any of the other groups? Okay, in that respect, then I think if I can then take the floor and then use this opportunity, we have a few more questions which are very interesting. But taking on from that point on collaboration and policy and moving it towards policy, many of us are working in advocacy, myself included, my colleagues included. What sorts of advocacy efforts should we be doing with policymakers in country? What sorts of arguments should we be making? What sorts of coalitions should we be drawing on? What techniques, what messaging can any of you recommend? I just also want to go to what one of our colleagues on the call has asked. Satya Kare has made a very interesting point, which has also made me think about this idea of what we need to do in terms of the policy push. Given the promise in screening, we will inevitably see more advanced stage diagnosis. And so Satya asks, do you think this will alert the population to the importance of screening? So I would ask the panelists to consider this question, the population to the importance of screening, but then equally, how do we alert the health authorities to the importance of screening? How do we move beyond a firefighting approach, which many of our countries are taking on at this moment, to a more long-term, thoughtful approach to cancer control, such that we are inevitably going to be seeing a wave of cancer cases? Pramesh, you have talked about the decrease in referrals by 50% or more. Now, as you rightly said, those cases haven't gone away. They will be coming back into the health system at a much later stage, which is more costly, more difficult to treat. And that's not just the situation in India. So what do we need to be telling our policymakers, and what do we need to be talking to the public about? I know that some of you have touched on this, but I would really like to hear from each of you on both of those 2 points before we close out for today. So I'm going to start with Erica.
Great. So, Sonali, I think that there are the 2 points. One is the collaboration. How do we alert the population? And so I think that the collaborations are going to be key. And I think, all of us around the virtual table here have a role to play. Advocacy organizations have an important role in telling the story of impact of the pandemic on their patient groups, and have different levers than those of us who are working in government or in government-sponsored organizations such as myself. The question that Satya puts forward, do you think that the plummet in screening will alert the population, I think is an interesting one, and one that we need to explore. In the past in Canada, when we've been looking to introduce screening programs, what we've heard from the public has been, do not use a fear-based approach to driving why to screen. Position this as part of a healthy, health-promoting behavior. And I don't know whether that has shifted at all, right? Certainly what we're hearing from our patient and family reps is that there's now more than ever, it's important to discuss the benefits of screening and how screening can be done safely in acknowledging the context of the pandemic. We have seen, though, that modeling the impact of pausing screening services has resonated with jurisdictions to help quantify these services and position them as an essential service, as one of as Pramesh spoke to. And so I think that does help increase the priority of cancer screening and puts screening programs at the decision-making table as the health system is having discussions for how to shift with subsequent waves of the pandemic. So I think yes, the plummet in screening can be used, and quantifying that is helpful. But I think that equally importantly is all of us working together to again, put screening on the agenda, to tell the patient story of impact, and to work together on some novel solutions.
Thank you. And for policymakers, Erica, what's your advice to those of us who are working and trying to convince policymakers who are absolutely their heads buried in COVID and just want to talk about infectious diseases? And what sorts of arguments do you suggest that we make to them?
So I think it's a multi-pronged approach. I think certainly the data around impact is very important, and making it easy and digestible with solid recommendations for what would be helpful. So for instance, I think Jody, you spoke to endoscopy weights, and when decisions are made over endoscopy services, how screening programs can actually support the stabilization and the rationalization of those services in a positive way that will make them sustainable is an example. I think, also we are waking up to the context of the pandemic. I think certainly the sentiment perhaps in Canada was that this would be a 3 to 6 month, right? If we all socially distance, it will go away. And that's not proving to be the case. So we are the cognitive dissonance is disappearing, and we are in it for the long run. And I think that also opens up different policy windows to advance some of the innovations like the self-sampling and the things that the working group shared, right? There's a different receptivity, a different resonance for some of those advancements.
Thank you, Erica. Jody, the same questions to you. I'll ask you all of those. So one, how, taking on Satya's question, do you think this is going to alert the population to the importance of screening? How do we change the perceptions of the public? We've seen in the poll the reticence of the public towards accessing health services. And then secondly, how do we reach out to our policymakers? What arguments do we use?
Okay, thank you. So I think it's really interesting from my point of view to think about screening and symptomatic services differently. And I guess, thinking back to Erica's comment there, when we were thinking that COVID might be a short-term thing, actually when researchers were looking at it, the impact of missing one screening round wouldn't be that massive because the benefit is cumulative over multiple screening rounds, but it would be there. But how big would it be compared to some of the shifts we're seeing within symptomatic services? And there's still a big question, certainly in the UK, about what the actual impact will be because we haven't got the data coming through just yet. We expect it will be a negative shift, but just how much remains to be seen. In terms of thinking about the public and how we can use that, CAR UK has been hugely active in creating media stories around the impact of COVID on cancer services. And we have had a huge amount of interest across a whole range of media about that. I think what's really interesting, though, it comes back to some of the reflections in the poll that we did earlier in the session around how people's impressions about treatment and what the next steps might be can really play into their decisions about how they act in response to screening invitations or symptoms. And if they feel that there isn't a good service in place, that treatment's not there, that it's not going to be worth it, et cetera, might you undermine their participation? And so there's a balance to be struck there. And I think we're still very much trying to navigate that balance of keeping policymakers attuned to the risk and the challenge, as well as keeping patients kind of motivated to continue to act in a positive way. In the United Kingdom, we're very fortunate actually to have cancer strategies across most of the nations of the UK and government commitments to achieving ambitious stage shift targets and also to achieving big shift in survival. And it has been really helpful to be able to keep coming back to those and reminding about those, and keep shifting that lens between the near term and the long term, and always thinking about what is it that we can learn about the current challenges that will take us further towards what we ultimately want to achieve in terms of patient benefit and outcomes.
Right, thanks, Jodie. So it's really putting that in the narrative about what the country has been able to achieve, not rolling back that success, looking at where the country has come over the years, and how that could be, how policymakers, health services should not be dropping the ball on that momentum. Okay, that's great. Pramesh, for a country like India, huge country, large population, you've talked about the reticence, exactly that fear of the public. What sorts of things? You've already talked a little bit about what the Tata Memorial Hospital and the National Cancer Grid are doing. What would be your response to Satya's question, but then also on the policymakers, and what sort of policy work has the grid been able to do, if any?
Yeah, so I think both Erica and Jodie had alluded to this in their responses as well. I think there's no shortcut to good communication and ensuring that what we do reach the ears of who matters. And that's a similar approach that we've taken both at Tata Memorial and at the National Cancer Grid. So with the general public, the approach that we took was that go on a really concerted effort at spreading information about the consequences of delaying a cancer diagnosis and treatment, and emphasizing more positively on how cancer could be cured if diagnosed early. So that's a very concerted effort that we took to educate the public, even more so during the pandemic. The second bit that we did was to continue advocacy with the policymakers, the Ministry of Health, the health workers who were part of the exercise of a national screening program. But to me, what actually did the trick was to lead by example. So some of the screening efforts that we had kind of put on the back burner. So we lead a very large screening effort in some of the districts of Maharashtra. That's where we are located in. And in the initial couple of months of when the peak of the pandemic hit, we, like most others, stopped our screening activities. But gradually, as more and more information came in about the pros and cons of stopping screening, so we took a conscious decision that ensuring adequate precautions, much of which I think several of our panelists described, making sure that universal precautions were taken with masking, with distancing as much as we could in a screening activity. We went ahead and restarted our screening program. And after we got a month or a month and a half of data from what level of risk individuals who came for screening, as well as our own employees went through during the screening exercise, we found people far more receptive to understanding that the risk of restarting a screening program with adequate precautions was not very high. And that was, to me, probably the most convincing argument to restarting both these activities, both starting screening in the community as well as restarting diagnostic facilities in several hospitals.
Thank you very much. Thank you very much for those insights from India. So lastly, Amy, over to you. Thoughts on those two dimensions?
The patient voice is critical. I mean, I think the importance of screening is not questionable, but how is the question? Mm-hmm. We need to take a risk stratification approach for early detection in a very pragmatic way. Nobody wants cancer, but nobody wants COVID either. And routine screening, as of late, is a trade-off between potential exposure to COVID or maybe I don't have something, so I don't need to go today. Let's make it not a trade-off and easier to do in a safe environment, which would be ideally either at home or where those who still have to go to work, at the workplace, etc., work remotely and not from home. there are still multiple pandemic-related factors that can impact the motivation, and there are systems factors such as with the economy, the work furloughs, reduced public transportation, fear of getting sick and losing a paycheck. We need to address all of those if we're going to have a proper screening program in place and early detection. And that fits into the piece on how to reach policymakers. Cancer won't stop because of COVID. We can't keep swinging the pendulum based on the trends. We need resilient health systems, and alerting health authorities to the importance of screening. I don't think we need to do that. Authorities know, it's just that they've got so much going on, and this has been new in all of our lives. But let's take a pragmatic approach and together reimagine cancer screening and diagnosis during and beyond COVID.
Thank you. Thank you very much. So I think speaking the last lines you say, a pragmatic approach, absolutely. And I think what has been really wonderful in all of your presentations is that you've done that. You've shown us some really great examples of what can be done now and what we should be looking towards using in the future. So I just looking at the time and just wondering if there are any other last questions. We have a few minutes left. Are there any burning questions from the audience? If not, I'll hand over to Alessandro, and if there's anything Alessandro would like to add or to say before I'll close.
Thank you, Shanali. I'd just like to thank you for stepping in and sharing, hosting this session, and thanks to our speaker, Erica, Jody, Ramesh, and Amy for giving us such an insightful views around the topic of today. Thanks to the participants. To those particular of you who stayed till the end, apologies for some of the disruption, possibly in the breakout groups, but hopefully this was an interesting and insightful conversation and the start of the conversation as well, not the end of it. So before closing, just want to remind you this is the first session of the series that will continue. The next one will be on the 17th of November about bringing quality cancer care closer to patients, and it will culminate on the 1st of December with the final session on making the case for investment for cancer. So hopefully you will join us then too. As soon as we close here, you'll be redirected to a survey page where, if you wish, you can leave us your feedback on today's sessions and any ideas for the future. Otherwise, I hope to see you at our next sessions, and please be safe wherever you are. All the best, and thanks to our panelists. Thanks, everybody.
Yeah. And I'd just like to add my thanks to our wonderful panelists. Your experience and your insights are really invaluable. I have really learned a lot and really enjoyed talking to you. So thank you, and thank you to all of our participants today. We'll continue to be in touch. Bye-bye.